Welcome back. This is Dr. G. Happy Hump Day. And today we're going to talk about not your normal pressure injury ulcer, not because it's dramatic, but the skin is actually telling you something that's going on when this ulcer happens. And we're going to talk about it. We talked a little bit about it in the hospice episode, but we're going to talk today about the Kennedy terminal ulcer. This is a wound that appears suddenly, expands fast, and often shows up when the body is shutting down. And we're going to connect it a little bit with something we already know well, which is diabetes, microvascular disease, perfusion failure, inflammation, and why a diabetic body might be primed for a perfect storm with this. But this episode is about the science behind the Kennedy terminal ulcer, compassion, documentation, and the truth. Because this wound is more like a messenger than anything. And medical disclaimer, let's make common sense common. This is for educational purposes only. Do not use it to replace medical care. I do not like when people try to do their own medical care at home. Do not do that. Okay? Absolutely no. And always use your clinical judgment when you're a healthcare provider, facility protocols, and local guidelines. But education is power. Okay? So, the Kennedy terminal ulcer. This traditionally described as a rapidly developing, rapidly progressing skin and soft tissue injury, classically appearing along the sacrum or the coccyx in a patient who is near end of life, often despite the appropriate prevention measures. It commonly described with patterns like butterfly, pear-shaped, or horseshoe-shaped, and the colors can be from purple, maroon, black, or yellow. And it does have a sudden onset. So sometimes they've called it the 330 syndrome, and the skin will look okay at the start of the shift, and by the end or later in the shift, the same person shift, the discoloration can appear suddenly and enlarge dramatically. And here's the important truth about the Kennedy terminal ulcer. It exists in a messy overlap zone between a classic pressure injury physiology and a skin failure slash end of life physiology collapse. So, depending on the guidelines, it may be discussed as a subset of a pressure injury at end of life or what they call scale, a manifestation of skin failure, or what they call scale. Like I said, scale stands for skin changes at life's end. So, how did this get discovered? So, the phenomenon was first described in the late 1980s. So, this is recent. A commonly cited origin is 1989, attributed to Mary Lou Kennedy in Fort Wayne, Indiana, describing a distinct pattern of skin breakdown in dying patients that rapidly progressed. Over time, clinicians observed similar lesions and labeled it the Kennedy terminal ulcer. And that stuck in the wound care culture, especially when it came to long term care or hospice. And then a debate exploded. Is this a pressure ulcer that happens to occur at end of life, or is this a separate end of life skin failure event that is often unavoidable? So this debate shows up in literature. One paper famously argued that like is it like the death of the Kennedy terminal ulcer concept, while others argued it remains clinically useful and you have to recognize the patterns in practice settings. So, what is the scale concept? Okay. So, scale, like literally the word scale, SCALE. So, skin changes at life's end comes out of the consensus effort to describe the reality that the skin can fail as the organs fail. So, the key scale idea is that when perfusion drops, oxygen delivery drops, inflammation rises, and the body is triaging for survival. And the skin is not on the top of their priority list of surviving, helping it to survive. So, scale, the skin changes at life's end frames this as an end of life wound as part of a larger systemic failure and not always as a simple pressure care failure injury. So, what is the mechanism of this? So, first, perfusion collapse and the skin as an organ. So, the Kennedy terminal ulcer is often discussed under skin failure, meaning that the skin cannot maintain the integrity due to hypoperfusion, hypoxia, impaired waste removal during critical illness or dying. So, think of it heart failure, that causes fluid backup, renal failure that causes toxins to accumulate, skin failure, the tissue cannot survive the perfusion slash inflammation collapse. Next is the pressure, also shear forces that still matter, but the tissue tolerance changes. So even if you're doing everything right with the repositioning, the pressure redistribution, moisture management, nutrition support, offloading, the body's tissue tolerance can drop so low that the normal pressure can become catastrophic. So it's not pressure irrelevant, but it's the pressure becomes a match in the room filled with gases. Okay. So, also, next is microthrombi inflammation at end stage physiology. So, at end of life, many patients have sepsis physiology, vasopressor use, DIC spectrum, microvascular clotting risk, profound malnutrition, and hypoalbuminemia, and anemia, and poor oxygen delivery. So, this creates a deep tissue ischemia and what you see on the surface is just the tip of the iceberg. So why the sacrum? Why is that the common region? The sacrum slash coccyx area. So this is a pressure prone in patients that are in supine. So supine is like laying on your back, right? And high shear during the micro movements and often is exposed to moisture and incontinence. You got to think about that. And then it is close to a bony prominence, so it has less padding and is a common site where perfusion is compromised along that patient. So, what does research say? So, Kennedy terminal ulcer research is very limited, and a lot of it is pretty much observational. Even recent clinical articles emphasize the scarcity of high quality prevention evidence of skin failure events like the Kennedy terminal ulcer. But useful things that we can see is that there's a high association with it with imminent decline. So the Kennedy terminal ulcer is often described as occurring close to death, sometimes within days or weeks, sometimes shorter, especially in frail patients or hospice patients or critical patients. Next, ongoing global terminology confusion. So there is a global disagreement about terms. So either calling it Kennedy terminal ulcer, or calling it a scale wound, which is, remember what we mentioned, terminal tissue injuries, unavoidable pressure injury, or skin failure. So the global wound care community survey highlight there is a terminology confusion and need for consensus when it comes to that, like the actual name of it. And the reality of it is some end of life skin changes may be unavoidable. So many clinical discussions and practice guideline documents explicitly distinguish avoidable pressure injuries versus unavoidable end of life skin injuries like a Kennedy terminal ulcer or scale or skin failure ulcers. So how does this relate to diabetes? Because this is called diabetic foot files, but you should know every wound, to be honest. So how could we connect the dots to diabetes carefully and scientifically? So Kennedy terminal ulcer is not a diabetic ulcer. It's not, okay? But diabetes can contribute to create a biological condition that makes the end of life skin breakdown more likely, more severe, and faster to progress. So things like microvascular disease, you have a lower reserve. So we know that diabetes damages the microvascular of over time, and the hyperglycemia drives endothelial dysfunction, there are basement membrane changes, oxidative stress, inflammation, which reduces the capacity to respond to ischemic stress. So, when a critically ill diabetic patient hits with hypotension, sepsis, vasopressors, anemia, and dehydration, their tissue may have less perfusion reserved and less ability to recover. Next is microvascular not micro, macrovascular disease and peripheral arterial disease, which is compounded hypoperfusion. So many diabetics have peripheral arterial disease and impaired arterial inflow. So combine that with end of life hypotension, and you get ischemic cascade that looks like a pressure injury, but fundamentally is perfusion failure. Next is neuropathy and the immobility. So the pressure and the shear exposure. So neuropathy reduces protective sensation, as we know. At the end of life, immobility is often extreme. So exposure to pressure or shear forces rises when the patient can self-shift themselves, okay? Next is the hyperglycemia immune dysfunction. We know that hyperglycemia impairs leukocyte function and increases infection risk, which can amplify inflammation and tissue destruction. And you also have to remember diabetic skin is not the same skin. Diabetes associated with impaired collagen turnover, impaired angiogenesis, impaired keratinocyte migration, and higher oxidative stress. So in translation, the skin repair system is slower. So when it fails dramatically. So diabetes may not cause a Kennedy terminal ulcer, but it can lower the patient's threshold at which the systemic decline becomes visible as a catastrophic skin injury. So again, what it looks like, how do we recognize it, clinical recognition of it? So like I said, the classic description is a sudden onset. The location is usually on the sacrum or the coccyx with discoloration, irregular edges. They usually describe the shape as butterfly shaped or pear shaped or horseshoe pattern shaped. Rapid progression from discoloration to necrosis with like slough or eschar. But, here's the pro move. Don't diagnose a Kennedy terminal ulcer by vibes. You don't do that. You diagnose it by context, pattern, and trajectory. So you're looking for, when we talk about trajectory, end of life trajectory, multi-organ decline, escalating support needs, a reduced intake, profound fragility, lesions appearing despite prevention. And before you label something as a Kennedy terminal ulcer, I think every clinician knows we have learned about differential diagnosis. So you have to consider your differential diagnosis as well, such as a deep tissue pressure injury, which is also maroon and purple and can evolve rapidly, moisture associated skin damages, which with secondary breakdown, incontinence dermatitis, ischemic necrosis from shock or vasopressors, purpura fulminans, okay, or thrombotic phenomenon, which is rare but critical, necrotizing soft tissue infection, which will have pain out of proportion and systemic toxicity, and calciphylaxis. Oh my gosh, I can't, I know how to pronounce this, but I'm just going to spell it for you. Calciphylaxis. And you usually see this in end-stage renal failure, and it's painful and necrotic. It's actually very hard to treat. So Kennedy terminal ulcer is a clinical narrative diagnosis, but it depends on the patient's whole story. It's not just a wound and you say, "That's it." Okay? And so when it comes to management of a Kennedy terminal ulcer, it's comfort over closure. Because remember I mentioned it during hospice episode, but it still requires high level care. So in hospice and end of life care, the goal, like we said, is comfort, odor control, exudate control, pain control, and helping the patient dignity and autonomy. So when it comes to pain control, they have to treat the pain proactively, baseline plus breakthrough. Use atraumatic dressing, so dressings that won't cause pain or more damage than good. Minimize dressing frequency when possible. Like we said, with odor or exudates, you can use charcoal dressing if appropriate, absorptive dressing, topical measures per protocol, and then make sure you protect the peri-wound borders and barriers. And then offloading and positioning, which are realistic goals. So continue pressure redistribution because, we don't want you to torture the patient with aggressive turning schedules if it causes the patient distress, but align the pressure redistribution with our goals of care, which is comfort. Next is if there is systemic infection suspected and treating aligned with goals, if the care is purely palliative, focused, controlled, and symptom controlled, and then family communication. So this can happen as the body is shutting down. So you have to make the patient aware of that. And we're still providing excellent care, but our priority is comfort and dignity for the patient. So the ethics about it. So Kennedy terminal ulcer cases can become conflict cases when the charting or documentation of it is weak. So there's something called a risk score, like the breeding score. Prevention measures in place, turning tolerance, comfort plan, nutrition, hydration status of the patient, perfusion status of the patient, hemodynamics, vasopressors, the end of life trajectory, goals and cares of discussion, wound timeline, like the onset, the size, the color, the evolution, photographs per policy, and family education. So you can't use Kennedy terminal ulcer as a lazy excuse and just saying like, oh, this is what it is. Okay. So don't let people like weaponize this diagnosis and just blame for no good reason. It has to be diagnosed properly. So let's do a quick case. So, an elderly patient with long-standing diabetes, chronic kidney disease, CHF, bedbound, poor intake, hypotension episodes, intermittent oxygen needs, increasing sleeping problems, on pressure redistribution surface, routine skin check should be happening. And in the morning, the sacrum looked and appeared intact with mild erythema. In the afternoon, there was a maroon butterfly shaped discoloration that appeared. And within the next 24 to 48 hours, there was increased darkening, necrosis, and decline accelerates. This is where the clinician must do two things: keep providing the best practice skincare for the patient and recognize the wound may be signaling a terminal physiology is going on. So let's do a quick board hypovoid question. So one, Kennedy terminal ulcers is most commonly associated with what clinical context? Is it A, uncontrolled diabetes alone, B, end of life multi system decline, C, venous insufficiency, or D, contact dermatitis? The answer is B, end of life multi system decline. Next, what is the classic location for a Kennedy terminal ulcer? Is it A, the heel, B, the lateral malleolus, C, the sacrum or coccyx, or D, the plantar forefoot? The answer is C, the sacrum and coccyx. Next, the 3:30 syndrome refers to what? A, pain pattern at 3:30, B, the wound appearing and enlarging within a single shift, C, a dressing change schedule, or D, the glucose pattern. It's going to be B, the wound appearing and enlarging within a single shift. For the best management priority in hospice for a Kennedy terminal ulcer is what? A, aggressive debridement no matter what? Absolutely not. You should know that. B, comfort, exudate control, odor control, and pain relief. C, hyperbaric oxygen, or D, skin grafting. The answer is going to be B, comfort, exudate control, odor control, and pain relief if the patient has a Kennedy terminal ulcer while they're in hospice. That's the best management. C, not C, next question. Diabetes may increase the vulnerability to end-of-life skin injury primarily through what? A, improved angiogenesis. We already know that's not true. B, microvascular dysfunction and reduced perfusion reserve. C, increased collagen strength. Or D, improved leukocyte function. It's going to be B, microvascular dysfunction and reduced perfusion reserve. 6. A key reason Kennedy terminal ulcers are controversial is it because of A, it never occurs on the sacrum, B, the terminology overlaps with pressure injuries and skin failure concepts, C, is always infectious, or D, it's always avoidable. The answer is B. It's controversial because the terminology overlaps with pressure injury and skin failure concepts. So the Kennedy terminal ulcer is not just a wound, it's actually, like I said, it's a messenger, it's a physiological message. Sometimes the skin finally saying SOS, unfortunately. And in diabetes with microvascular reserve compromise, the message might arrive louder, might be faster or more disruptive. But the job is not to win against death. Your job is to provide excellent care, excellent documentation, excellent compassion for the patient. Okay. So the patient is protected, the family is informed because education and power, and the team stays grounded in the truth. Okay. So hopefully this episode was helpful for somebody. It's a very interesting ulcer. I remember learning about it for the first time, and hopefully, if, if you'll be able to recognize it if you see it, unfortunately. And this is Diabetic with Files. I'm Dr. G, and take care of your feet because they take care of you.